Hi, I am Professor Amitabh Banerjee. I am a professor emeritus in community medicine and epidemiology. And I'll be talking about the health budget. This is based on a feature, on a commentary I had written, which was published 2 days ago in Double Helical. And the title is Band-Aid for Deep Wounds. So I have compared the yearly health budget as band-aids, which cannot take care of the deep wounds in our public health infrastructure since the past more than 70 years, since independence, one can say. So, and I have reasoned that health budget cannot be considered in a vacuum, but has to match with our public health priorities. That is where epidemiology comes in. We are not prioritizing our public health priorities, and I'll be discussing the gaps in our planning. And the debate around the meager allocation to the health sector has become a annual ritual. The discussion usually revolves around monetary allocations under different heads. The end result of these annual exercises is blaming the lack of money for the country's dismal health indicators. More important, however, I am just trying to emphasize that when you talk of health economics, money is not the main. More important is to debate and discuss how we allocate our meager resources to meet the health needs of a large population. Public health priorities are unique for each country. They cannot be taken off the shelf from another country or dictated by well-meaning international donors ignorant of our health needs. Health economics is less about money and involves consideration of resources and needs and often value judgments, which may elude quantification in monetary terms. The non-monetary inputs and judgments based on them may have more impact on overall health of the population than the total financial outlay in the health budget. There are countries with huge financial outlays on health, but the outcome in terms of population health is not commensurate with the money spent. The USA is a case in point. Americans are dissatisfied with their healthcare system in spite of spending more than citizens of other nations. The USA spends around 15% of the GDP on health compared to 11% in France and Germany, 10% in Canada, and 8% in the UK and Japan. Most countries of Asia and Africa spend far less, around or less than 5% of their GDP, which includes India, which is still on the lower side of Asian African countries. The USA with the high spending on health but low efficiency in terms of output should serve as a caution for other countries. Money not used wisely based on the country's public health priorities is money wasted. What are the reasons for inefficiency of the USA model of health budgeting? Because this is important because we are imitating the USA. Most countries, USA is the bellwether for other countries. The cause of inefficiency in USA is the increased consumerism in health driven by market forces, a bellwether for other countries. Market forces in medicine drove Americans to consume too much costly medical care of uncertain benefits. This demand pushed allocation inefficiency, where incremental money spent in the health budget did not translate into commensurate benefits. Advances in medical technology, often overhyped by market forces, skewed healthcare towards tertiary levels, neglecting primary and secondary levels of care. This is very pertinent for our country. Medical treatment at the tertiary level is becoming more complex in an attempt to achieve perfection with zero error expectations, leading to increased litigations and eroding trust among patients and doctors. Defensive medicine leading to a battery of investigations, often irrelevant, tending to focus on the treatment of chronic diseases rather than the that is to protect against possible litigation, further escalates the cost of medical care and allocation inefficiency. Various stakeholders enter the fray. The pharmaceutical and other industries got their skin in the game for return on their huge investments in R&D. The medical pharmaceutical industry has turned healthcare into a monolith with huge resources but poor vision. Primary and secondary care got neglected with investments focused towards tertiary care. Unhealthy diet and neglect of physical activity drive increasing levels of obesity and comorbidities of non-communicable diseases, which lead to demand for tertiary level healthcare. The COVID-19 pandemic drove home the point that healthy lifestyles is essential not only for prevention and reduced morbidity and mortality from non-communicable disease, but also good population level health can cushion the effects of pandemics. The Western countries, including USA, which have overweight 2 to 3 times higher than Asian and African countries, had 10 to 20 times higher death rates from COVID-19 compared to Asian and African countries in spite of far higher rates of vaccination. Most African countries had less than 5% vaccination coverage, but did not face the fury of the pandemic. Lessons for India from the American experience. There are important lessons from the American experience which we can ill afford to neglect. While we started with a sound roadmap for health based on the country's health problems and priorities, we seem to have lost the way over the years. Increasingly, we are going the American way, dominated by specialists and subspecialists pushing the first contact general practitioners in the background, if not into oblivion. Nobody wants to become general practitioners today. They have become the underdogs. Like in the USA, market forces increasingly are having an influence on our health policies. This can limit the vision for an objective analysis of our health priorities, which may get skewed towards off the self priorities from other regions or dictates of the market, resulting in allocation inefficiency. Inappropriate allocations however large in our health budget will not improve the health of a population. Regrettably, these dynamics are already in place. A brief summary of our health vision since independence and how we are straying from it would make us understand the nuances. India started with a sound roadmap for health around the time of independence. The Health Survey and Development Committee, known as the Board Committee, set out the public health priorities in India, based on which it gave its recommendations. The Board Committee report is vast in its scope and vision, which over the years since independence seems to be getting dimmer. The Board Committee noted the poor state of our health with high infant mortality rate and short life expectancy. It implicated insanitary conditions, poor public health infrastructure, poor nutrition, inadequacy of existing and medical preventive health infrastructure, lack of general and health education among the causes for the poor state of people's health in the country. The Board Committee stressed on the need for a frontal attack on these factors and awakened public opinion in the war against disease, which should not lose momentum with time. He stated that the economic losses the country faces due to malnutrition and preventive morbidity and mortality is colossal, a value judgment which misses out on most appraisals of the annual health budget. Nobody talks of these things because and still we have not addressed it. In its recommendations, it has stated that the health services should be an integral part of overall plan of reconstruction. Addressing health problems by frontal attack upon one aspect alone, piecemeal, as is the practice currently, can only end in disappointment and waste of money and effort. We are seeing in the recent times, we are tackling one disease at a time. We have tackled one only as if when the COVID was going, as if COVID is the only disease where people were dying. 25,000 people die daily in India of various causes. But that became the only disease. We are trying to solve one at a time, piecemeal. One disease, one vaccine. Now we are worried about disease X. Now we are worried about monkeypox. One disease at a time. But daily we lose 1,400 to tuberculosis. 4,000 children due to malnutrition and infections. So we are solving the problem piecemeal, which the Sir Joseph Bore had predicted that it will not solve the country's problem. It will only end in disappointment, one disease at a time, piecemeal. The board committee had planned a primary health unit for every 10,000 to 20,000 population, very important, with a 75-bedded hospital. At the village level, 10,000, 20,000 population, say block level, few villages, 10,000, 20,000 population, they recommended board committee 75-bedded hospital served by 6 medical officers, including medical, surgical, obstetrics, and gynec specialists, supported by other auxiliary staff. About 30 primary units were envisaged to be under a secondary unit having a 650-bedded hospital having all the major specialists. At the district level, it recommended a 2,500-bedded hospital providing tertiary care. So at the district hospital are in bad shape today, forget about tertiary care. Primary health center, one medical officer, whereas what was recommended was a 75-bedded hospital with a gynecologist. We have a very high maternal mortality rate because obstetrics care is not available. Even after 77 years of independence, achieving the status of the 5th largest economy in the world with 200 Indians in the Forbes 2024 billionaires list, India ranks 111 out of 125 countries in the global hunger index. It ranks among the countries with the highest rate of child malnutrition and anemia. An estimated 4,500 under 5 children die in India daily to preventable disease against a background of malnutrition. Among communicable diseases, India contributes to a quarter of the global burden of tuberculosis. 1,400 Indians dying daily due to TB in the country. Dengue, chikungunya, Zika, Japanese encephalitis, malaria, and other vector-borne diseases are rampant in the country. It is embarrassing that we have not reached the level of health which developed countries had achieved before the start of the Second World War. How we can have a health budget which can take care of all this when for 77 years it was neglected. How did we stray from the path laid out by the board committee and lost the way? Former president at AIIMS New Delhi, Dr. Bidhu K. Mohanty, an oncologist, states that the Indian healthcare system has passed through 3 stages, 1952 to 1980, 1981 to 1992, and 1993 to the present. In the first 30 years after independence, in line with the board committee report, the health services, in addition to private general practitioners, were mostly provided by salaried government doctors and the 3-tiered public health infrastructure at the primary, secondary, and tertiary levels. The primary and secondary levels of healthcare were at the village, taluk, and district levels to treat the majority of the diseases and also provide preventive and health promotion services free of cost. Of course, we attained ideal conditions. We never could attain a hospital for 10, 20,000 population, 75-bedded hospital with all specialists. The next decade saw the slow decay of the public health infrastructure due to the overall economic collapse. After 1980, there was economic collapse. Government spending on medical education, which erstwhile was its sole responsibility, faced stagnation. Several private medical colleges started in the 1980s, starting with the southern states, after which there was no looking back. Currently, half of the medical colleges in the country are private. Similarly, public hospitals face resource crunch, and to cope, a number of public-private partnerships evolved. Big tectonic shift after 1992. There was a paradigm shift in the economic model after 1992. This triggered enormous changes in the health financing system, which spilled over in the 21st century. A complex hybrid model of healthcare delivery with no clear vision and increasing influence of market forces. The emphasis which the board committee report put on the neglected aspects of public health, leading to a large amount of preventable morbidity, became the underbelly of our shining reputation as the favored country for medical tourism. Due to a 5-star tertiary care, corporate hospitals providing the state-of-art medical treatment. Market forces, a necessary evil in the era of huge technological investments for R&D in drug discovery and medical devices, have transformed medicine into an industry. Chasing the glitz and glamour of high-tech medical industry, we strayed faster and further away from the roadmap of the board committee, which had envisaged a hospital with 75 beds for 10,000 to 20,000 population as a primary health unit at the rural level, the taluk or sub-divisional area to have a 650-bedded secondary multi-specialty hospital, and each district to have a 2,500-bedded tertiary care hospital. We strayed, everybody forgot of this report. We gathered dust. Post 1992, that is the liberalization, economically liberated India, with its emphasis on GDP growth and increasingly privatization of the health services, had failed in inadequate resource allocation to meet the demand for robust public health infrastructure. In this vacuum, the private entrepreneurs thrived. More than 60% of OPD attendants, 70% of hospital beds, and 80% of doctors are in the private sector. Medical and nursing education, which lays the foundation of the healthcare system, has witnessed increasing private investment with government approvals. It is debatable whether these developments can someday meet the healthcare needs of the country, particularly of the poor and marginalized and in the rural areas. From time to time, government does make attempts to address the long neglected public health infrastructure, which could be accessed by the less privileged who could not afford private healthcare. The National Rural Health Mission, launched in 2005, which was the forerunner of the more ambitious National Health Mission, which has two components, the National Rural Health Mission and the National Urban Health Mission. While these programs are well planned, their execution was a challenge. The recent budget also gave the stepmotherly treatment to the National Health Mission. Another attempt to offer affordable health services to the poor was the Ayushman Bharat program, launched in 2017 and included in the health budget of 2018-19. The Ayushman Bharat project had two components. First, the delivery of comprehensive primary health care by upgrading 150,000 health and sub-centers and primary health centers to health and wellness centers by the year 2022. And secondly, catering for secondary and tertiary level medical care under Pradhan Mantri Jan Arogya Yojana. It was claimed that Pradhan Mantri Jan Arogya Yojana is the world's largest health program. What is paradoxical is that no significant financial provisions were made to beef up the ailing public health infrastructure in the country. It was just shuffling the old pack of cards and benefiting the private hospitals by including them in the insurance scheme of Ayushman Bharat. The Finance Ministry allocated 1,200 crores for the health and wellness centers in 2018-19, which translated to 80,000 rupees, 80,000 per center. Essentially, it was just a thin coat of paint for the old primary health center, which were renamed for the occasion. Primary health wellness centers, and each primary health center received 80,000. What is 80,000? Just the repair of the building only will take 80,000. The budget allocated for PMJ, that Prime Minister Jan Arogya Yojana, in the launch of 2018 was 2,000 crores, which was twice the previous year's budget for the Rashtriya Swasthya Bima Yojana, the PMJ's predecessor, which got engulfed under the Prime Minister Jan Arogya Yojana. Essentially, both the components of the Ayushman Bharat program, the health and wellness centers and the Prime Minister Jan Arogya Yojana, amounted to shuffling the same deck of cards with only got a shiny new cover. Both these schemes covered breadth but lacked the depth. It was a thin coat of paint. Health budget. Now it comes to the recent health budget 2024-2025, a band-aid to cover deep wounds in the public health infrastructure. The health budget for 2024-25, appraised against the background of our decaying public health infrastructure over the past 7 decades or more, would seem like a misplaced band-aid over the deep wounds our public health has suffered over the years. The budget has allocated about 90,958 crores to the Union Health Ministry, a 12.9% increase from rupees 80,000 crores in the revised estimates for the Health Ministry 2023-24. There is a 12.9% increase from the previous. Of this, 87,000 crore has been allocated to the Health and Family Welfare Department and 3,301 crores for health research. The budget for AIIMS New Delhi has been increased marginally from around 4,000 crore to 4,273 crore to 4,523 crore. I mean, hardly any difference. The government has also announced customs duty exemptions of 3 cancer treatment drugs and has reduced customs duty on X-ray tubes and flat panel detectors. The marginal extra allocation may appear to be a slow but steady focus on health, but it hides the truth that it fails woefully short of considering the enormity of the country's health challenges and failed promise on the Bhor Committee report, which was tabled around the time we had Christ with destiny, the phrase coined by your first Prime Minister. What is more concerning is that some of the criticisms of the budget is also wide of the mark. For instance, one of the concerns is that there is no incentive to industry that can bring private healthcare closer to the common Indian, overlooking that there are hardly any private hospitals in rural areas where the majority of our population live. There can be no shortcuts to public hospitals in rural areas, which would require huge investments to catch up with the steady neglect over the years. Another regret expressed by experts is that the National Health Mission was to roll out the nationwide cervical cancer vaccination program, the HPV vaccine, as announced in the interim budget. This is also a grossly misplaced criticism. Both planners and critics as well demonstrate the amateurish approach in determining public health priorities. Even the Rajya Sabha member Srimati Sudha Murthy, in her maiden speech in the House, urged the government to launch the HPV vaccine for girls. The proposal to include the HPV vaccine in the National Immunization Program is the perfect example to illustrate how health policy makers are far distant from ground realities, are influenced by the market forces and propaganda, even film stars joining in the latter exercise. They sell vaccine like they sell Coca-Cola, the film stars also. Before we consider investing huge amounts of money for including the HPV vaccine in the universal immunization program, several issues have to be resolved. The vaccine trials of HPV vaccine had a checkered past in our country. The Program for Appropriate Technology in Health, PATH, sponsored by the Gates Foundation, conducted HPV vaccine trials in Andhra Pradesh and Gujarat in 2009-10. The trial was deliberately labeled as an observational study instead of a trial to circumvent thorny ethical issues. There were mishaps during the trial. Some girls died. The Indian Council of Medical Research, which was partnered in the trial, tried to pass off these deaths as coincidental. However, a government committee investigated the matter. The report is available in the public domain and should be re-examined before committing any further misadventure with the HPV vaccine. Subsequently, the 72nd Joint Parliamentary Committee investigated the matter and tabled its report in both houses of Parliament on August 30, 2013. It indicted the PATH and the ICMR of gross irregularities and found many individuals and institutions guilty of dereliction of duty. It also questioned the ICMR's role of promoting the vaccine before any proper study of its efficacy. The Joint Parliamentary Committee also recommended that the matter should be investigated by a premier investigating agency. It has been more than a decade since this recommendation, and still there have been no detailed probe by any agency. On the other hand, the policymakers have come full circle and again promoting the HPV vaccine, this time with propaganda than science, involving film stars and celebrities who cannot be expected to understand the nuances of the science behind the disease and the vaccine. Mass rollout of the HPV vaccine, which caused deaths of teenage girls during trials in our country, before we have a proper public health infrastructure to monitor adverse events, if any, would be like running fast trains on old rickety tracks. There are other issues besides this misadventure. The efficacy of the HPV vaccine has been questioned in a peer-reviewed paper published in the prestigious Journal of the Royal Society. The title of the paper is "Will HPV Vaccine Prevent Cervical Cancer?" by Rees et al. The paper summarized that the trials were not designed to detect protection against the outcome, cancer, which takes decades to develop, Follow-up was limited to 4 to 5 years. While vaccines may prevent very early pre-cancer disease, most of them could be self-limiting. Surrogate markers were taken to test the efficacy. Prevention of these surrogate endpoints may not confirm the efficacy. Most trials reported relative risk, which overstates the efficacy instead of the attributable risk that is marginal. While the jury is out, a recent paper published in the journal BMC Cancer, published by Springer Nature, revealed that incidence and deaths from cervical cancer over the last 3 decades have fallen sharply in India. Vaccine manufacturers involved in propaganda with help from film stars and celebrities would not like to highlight these facts. We should see the data first. If our policymakers and philanthropists are really interested in preventing deaths from cervical cancer, they should ensure availability of hospital services equitably across the country as laid down in the board committee report. This will ensure cervical cancer screening, which is the seat anchor in prevention of cervical cancer, and not the HPV vaccine with uncertain evidence and possible adverse effects if we go by the misadventure during the surreptitious trials of vaccine in the country. A cost-effective analysis in Australia showed that HPV vaccine is not cost-effective in settings with established cervical screening. Public hospitals equitably distributed across the country will also bring down the unacceptable high rates of maternal deaths in our country. Infant mortality under 5 malnutrition, which is one of the highest in the world. Or maternal mortality, almost 90 mothers die per lakh due to normal childbirth. And the cervical cancer deaths is 10 times more, or young mothers are dying. And cervical cancer deaths are 9 per lakh. And even the manufacturers, vaccine manufacturers admit that even after giving the HPV vaccine, cervical cancer screening is a must if you want to reduce the death. So it doesn't do away with cervical cancer screening. And since the large number of women in our country do not have access to cervical screening because there are no gynecologists in the rural areas, only all are concentrated in the urban areas. So HPV vaccine is again a band-aid. The way forward. So the national, so anyway, cost and public hospitals are the main answer. The National Health Mission, which is a feeble attempt to improve health services for the vulnerable and marginalized, received just 1.16% increase in funds. National Health Mission was an ambitious plan to give health cover to the rural areas and the urban poor. It just received 1% increase in fund allocation over the last year's revised estimates, and the bulk of that was going to the HPV vaccine program, which included the ill-conceived HPV vaccine program. HPV from 9 to 13 years girl, all the girls and with certain mothers are dying, under 5 are dying before they reach the age of getting cancer. And you are giving HPV vaccine. Immediate deaths, 400 children dying daily, 90 mothers per lakh dying in childbirth. In front of your eyes, and you are thinking you give a HPV vaccine now to prevent cancer 30 years later. The way forward is to take many steps backwards. What is the way forward? To take many steps backwards. It's a big, unglamorous, therefore no one will really try it. Yearly allocations for the health sector since decades have been too little and too late. With every year, we are drifting further away from the public health policies which can improve the health of our people. We have to expand the public health infrastructure across the length and breadth of the country. Increasing number of high-rise hospitals confined to big cities indicate that the course correction has not started yet. What we are doing, we are having AIIMS in every city now and high-rise hospitals. We require the breadth of coverage rather than the height of coverage for all buildings. Private players are important in the health sector, but too much dependence on the private sector with their own conflicts of interest will lead to further neglect of public health hospitals and health centers. Our health planners seem to be influenced by the disastrous American model promoting medical consumerism, benefiting the pharmaceutical and medical devices industry. While the latter are definitely vital to deliver state-of-the-art healthcare, we need a more balanced approach of primary and secondary level care to prevent people landing up in tertiary hospitals with costly treatment options. This will escalate the cost on health further with diminishing returns. More need for tertiary beds means you have failed in your primary and secondary care. The step forward will be to go many steps backwards, wipe the dust of the board committee report and implement its recommendation. Not an easy task and certainly not as glamorous or lucrative as promoting medical tourism, high-rise hospitals, pharmaceutical products, and pushing medical consumerism. Till then, the annual health budget debates and discussions will be futile exercises with hardly any impact on the health of a people, even if the budget is increased many times over. Good planning based on scientific evidence and needs of the people is more important in health economics than money per se. So this is take on the health budget. We are going through the rituals. Thank you so much. I am uploading it on my YouTube. I'll be putting some references